Thank you, Madam Chair. Um, May I ask just a question on Dr. Moffat? You had, in your testimony, you had been open to the issue of, I think, pay for performance and hospital readmissions, the policies, how well it's done, it seems to be what your question is. On the hospital readmission, in President Obama's budget, there seems like there's both a carrot and a stick. It isn't just a stick, and I'd appreciate it, sir, if you could comment upon this, because your testimony indicated there was more of a stick there rather than any carrot. So how would you construct it, or to make sure, sir, if it was done well? I mean, he kind of bundles his payment with the 30-day afterwards with an acute provider, so there's a little carrot there, and a little stick of a little less payment if they have to come back. What would you do to make sure this works?
I'm not certain. I am not certain. I like.
So you're not opposed to the idea, you're just not certain how to execute.
No, as I said in my testimony, I think that the objectives of this are very, very good. I think it's exactly.
Would his proposal of comparative research help in this area? To give us something?
Well, his comparative research, the comparative effectiveness focuses primarily on medical treatments and
comparative effectiveness
devices. Yeah, but no, I think the president is addressing what I think personally is probably one of the weakest elements of the American healthcare system, which is the sickness or spells of illness that happen to the elderly, where they end up in hospital intensive care units, usually for a week or 2 weeks. They're there for a while. Oftentimes, there's a great deal of confusion about, you have the young people coming to see their parents, and they're trying to find out exactly, what their situation is. They're there for a spell of time, and then they're sent to from the hospital emergency room from the intensive care unit to some skilled nursing facility.
Right.
And they're there for a while. And sometimes in that kind of well, in fact, not sometimes, I'm afraid too often, there's a breakdown in the community, in the continuity of care. And they're there for a while, and then they're sent back to the hospital. There's clearly, the president's objective here is exactly right. Yes.
I mean, it's not dissimilar to a vet getting out of the Department of Defense and trying to find his way through the VA.
Right.
And if I could, that's why I'm quite taken, if I could, and ask you, sir, how might you do it? You were a little more concerned, I think, that you're going to get a little less cost if he comes back to you to pay. The reason I am is, it's the question that's come up here several times of how do we pay for all this?
Right.
In everything research, at least I've done, the way we pay for this is efforts like yours, doctor, the preventive care, if you really do go to these patient-centered medical homes. If the savings that they can bode, or the savings that we can get out of this pay for performance, or how we do it, that, to my mind, is the real pay. Almost simultaneously, we need to do HIT and other things. Do you disagree with that approach?
No.
So how would you do this?
Well, I think with regard to there's two things here. One, pay for performance is a separate issue, I think, from the hospital admission issue. Physician pay for performance is a separate issue. But I like, in principle, the idea of bundling the payment to the hospital for spells of illness in certain cases. I think if we start paying for results, that is where we ought to go.
I agree. I need to move over. And results in the terms, particularly
results in terms of outcomes.
Right. The preventive care.
Well, not just preventive care, but when we have people in the emergency, when we have people in the intensive care unit, we don't want them. We don't want the frequent flyers from the skilled nursing facilities back to the intensive care unit.
If I could just move, and I know that you're a special case in the sense that your data is less and that, but how would you set this very important critical area up?
Certainly, hospitals look forward to doing the bundling. We're not
less data because hospital, where
right.
you are.
Our concern is oftentimes as you look at the path of treatment for patients, especially in rural communities, it may start in a physician's office, come to a hospital for a part of the admission, diagnostic testing, and then get transferred to another facility to have some level of care performed, and then the patient or their family requests that patient be moved back to the rural community closer to home. And so as we bundle that, how are we going to come up with the proper way in which to make sure that all of the parties who are taking care of the patient are properly paid. In rural communities, we often have limited number of partners in which to pair with. For instance, in our community, there are only 3 home health agencies, only one of which takes Medicare patients today, and only one of which has a physical therapist as a part of that home health person. So as we bundle care, and that patient needs to go to home, and that care is bundled under that payment, there may be some delay in getting care to that patient because of the limited resources in rural communities. And so that is the concern. It's not that we're opposed to it. It is that we want to make sure that it is done fairly and appropriately.
Thank you. I've run over my time. I was curious how you would construct it.